There is a number that your doctor has almost certainly told you to aim for, and there is a very good chance that number was never designed with you in mind. If you are 70 years old or older and you have been told to get your blood pressure below 120/80, or even below 130/80, you are being given a target that was built primarily around research conducted in middle-aged adults. And applying that target rigidly to a 70-year-old body is something that the medical community itself has been actively debating and revising for years. This video is not about telling you to ignore your doctor. It is about giving you the information you need to have a more complete and more honest conversation with your doctor, because the truth about blood pressure targets at 70 is significantly more nuanced than most patients are ever told. Stay with us until the end, because the information coming up about what the target should actually be and why it matters so much at this stage of life is the part that most people over 70 desperately need to hear. Let's start by understanding where the standard blood pressure targets came from and why they became the universal benchmark that they are today. The foundation of modern blood pressure guidelines was built on research conducted primarily in the 1970s, 80s, and 90s, during which large clinical trials demonstrated that reducing blood pressure in people with hypertension significantly reduced their risk of stroke, heart attack, and cardiovascular death. These findings were genuinely important and changed medicine for the better. But here is the critical detail that often gets lost in translation from research to clinical practice. Many of the landmark trials that established current blood pressure targets either excluded or underrepresented older adults, particularly those over 75. The populations most heavily studied were predominantly in their 40s, 50s, and 60s, and the targets that emerged from those trials were then applied across the board to patients of all ages, including those in their 70s, 80s, and beyond, as if the physiology of a 75-year-old body were interchangeable with that of a 50-year-old body. It is not, and the growing body of research specifically focused on older adults has been making this increasingly clear. To understand why the physiology is different, it helps to understand what blood pressure actually does inside an aging body. Your blood pressure is not simply a measure of cardiovascular risk. It is also a measure of the force required to push blood to the organs that need it, including the brain, the kidneys, the heart itself, and every other tissue in the body. In a 25-year-old with supple, elastic arteries and excellent cardiovascular reserve, the heart can generate adequate perfusion to all organs even at relatively low blood pressure levels. But in a 70-year-old whose arteries have naturally stiffened over decades, whose heart muscle has changed, and whose overall cardiovascular reserve has declined, the pressure required to deliver adequate blood flow to vital organs, particularly the brain, is meaningfully higher than it was 40 years earlier. This is not a failure of the aging body. It is a physiological adaptation. The higher blood pressure seen in many older adults is in part the cardiovascular system's way of ensuring that the brain and other organs continue to receive the perfusion they need despite the reduced compliance of the arterial system. This is why bringing blood pressure down aggressively in an older adult can sometimes, paradoxically, cause more harm than leaving it at a level that would be concerning in a younger person. This is where the concept of the J-curve becomes essential for understanding blood pressure management in older adults. When researchers plot blood pressure levels against cardiovascular outcomes in older populations, they consistently find something that doesn't appear as prominently in younger populations. Risk doesn't simply decrease linearly as blood pressure comes down. Instead, risk decreases as blood pressure is lowered from high levels, reaches a lowest point at some intermediate level, and then begins to increase again as blood pressure continues to fall below a certain threshold. This J-shaped relationship means that both too high and too low represent elevated risk, with an optimal zone somewhere in between. The critical question, and the one that has been the subject of considerable research debate, is exactly where that optimal zone sits for a person who is 70 versus a person who is 50. The evidence increasingly suggests that this optimal zone is meaningfully higher in older adults than in younger ones, and that the one-size-fits-all targets derived from middle-aged populations may be pushing some older adults below the nadir of their J-curve into a zone of increased risk rather than reduced risk. The research on this question has evolved considerably over the past decade. The SPRINT trial, which was published in 2015 and generated enormous attention, found that targeting a systolic blood pressure below 120 in adults with cardiovascular risk factors reduced cardiovascular events compared to targeting below 140. This finding led many guidelines to lower their recommended targets, and it was widely interpreted as confirming that lower is better. But the story is more complicated than the headline suggested. The SPRINT trial used a specific method of blood pressure measurement, automated and unattended, that consistently produces readings several points lower than the standard office measurement most people are familiar with, meaning the actual pressure being targeted was higher than the numbers suggest. The trial also found that the more intensive treatment group had significantly higher rates of acute kidney injury, low blood pressure episodes, fainting, and electrolyte abnormalities. And when the subgroup of participants over 75 was analyzed separately, the benefits were more modest and the harms more pronounced than in younger participants, highlighting precisely the kind of age-related difference that makes uniform targets problematic. Other major research has provided additional nuance. Studies specifically focused on very elderly adults, those in their 80s and above, have produced findings suggesting that in this age group, blood pressure that is somewhat higher than standard targets may actually be associated with better outcomes than more aggressively lowered pressure. One influential study following adults over 80 found that systolic pressure in the range of 140 to 150 was associated with better survival and cognitive outcomes than either higher or lower readings in this population. Research specifically examining cognitive decline has added another layer of concern, with some studies finding that aggressive blood pressure lowering in older adults was associated with faster decline in certain cognitive functions, possibly because inadequate cerebral perfusion in an aging brain with less reserve contributes to cognitive deterioration over time. What does all of this mean practically for someone who is 70? It means that the appropriate blood pressure target at 70 is genuinely individual in a way that it simply isn't at 40, and that the right target for you depends on a set of factors that go well beyond the single number your doctor may have given you as a goal. It depends on whether you have a history of stroke or transient ischemic attacks, which would typically push toward more aggressive treatment. It depends on whether you experience symptoms of low blood pressure, such as dizziness when standing, lightheadedness, or falls, which may suggest your current pressure is already too low for your physiology. It depends on your cognitive status and trajectory, since emerging evidence suggests that cerebral perfusion needs to be protected in people with or at risk for cognitive decline. It depends on your kidney function, since aggressive blood pressure lowering can accelerate kidney function decline in older adults with already reduced filtration capacity. And it depends on your overall frailty and functional status, since a robust, active 70-year-old who exercises regularly has a very different physiological reserve from a 70-year-old who is frail, sedentary, and managing multiple chronic conditions simultaneously. The concept of frailty deserves particular attention here because it is increasingly central to how geriatric medicine specialists approach blood pressure management in older adults. Frailty is not simply about being old or even about being sick. It is a specific clinical syndrome characterized by reduced physiological reserve, increased vulnerability to stressors, and a decreased ability to recover from challenges to the system. People who are frail, even at the same age, respond very differently to the same blood pressure treatment compared to people who are robust. In a frail older adult, the compensatory mechanisms that would normally maintain organ perfusion when blood pressure drops are less reliable, meaning that a blood pressure level that a robust person would barely notice could cause dizziness, falling, reduced kidney function, or even cognitive changes in someone who is frail. This is why many geriatric medicine specialists now use frailty assessment as a key factor in determining blood pressure targets, and why the emerging consensus in geriatric cardiology is that treatment should be calibrated to the individual's physiological reality rather than to a population-level target derived from a very different age group. Let's also talk about the specific danger of orthostatic hypotension, which becomes a critically important consideration in blood pressure management at 70 and beyond. Orthostatic hypotension is a drop in blood pressure that occurs when a person moves from lying or sitting to standing, and it becomes more common and more pronounced with age because the autonomic nervous system's ability to compensate rapidly for positional changes deteriorates over time. When blood pressure medication brings a person's resting or seated pressure to an aggressively low target, their standing pressure may drop to levels that are genuinely dangerous, causing dizziness, unsteadiness, and falls that can result in fractures, hospitalizations, and a cascade of complications. Falls are one of the most serious health risks for adults over 70, and blood pressure medication is one of the most well-documented contributors to fall risk in this population. This is why a blood pressure target that looks appropriate on paper when measured in a seated clinical setting can be actively harmful for the same person in their daily life, when they stand up from a chair, get out of bed, or climb stairs, and why orthostatic blood pressure measurement, checking pressure both sitting and standing, is an essential part of managing blood pressure safely in older adults. What should you actually do with this information? Let's also take a moment to discuss something that rarely comes up in standard clinical conversations about blood pressure, which is the connection between blood pressure management at 70 and cognitive health. The brain at 70, particularly one that has been managing cardiovascular risk factors for decades, has a reduced ability to autoregulate its own blood supply compared to a younger brain. Cerebral autoregulation is the brain's mechanism for maintaining consistent blood flow across a range of systemic blood pressure levels, essentially a self-protective buffering system that keeps the brain supplied with oxygen and nutrients even when blood pressure fluctuates. In younger adults with healthy cerebral vasculature, this autoregulation works efficiently across a wide pressure range. In older adults, particularly those with a history of hypertension, diabetes, or cardiovascular disease, this autoregulatory range narrows, meaning the brain becomes more sensitive to blood pressure changes in both directions. Over time, repeated or sustained episodes of insufficient cerebral perfusion in an older brain with limited reserve may contribute to cognitive decline, white matter changes visible on brain imaging, and in some cases vascular dementia. This is one of the neurological arguments that has emerged in geriatric medicine for being cautious about over-aggressive blood pressure lowering in older adults, and it adds a dimension to the blood pressure conversation that goes well beyond cardiovascular risk calculations alone. There is also a medication burden consideration that becomes increasingly important at 70. Many adults at this age are already managing multiple chronic conditions with multiple medications, and polypharmacy, which refers to the use of multiple medications simultaneously, carries its own set of risks that interact with blood pressure management in complex ways. Blood pressure medications interact with many other commonly prescribed drugs in ways that can amplify their blood pressure lowering effects beyond what was intended, cause electrolyte imbalances, affect kidney function, or contribute to falls through combined effects on blood pressure and balance. This is one reason why medication review focused on deprescribing is considered by many geriatric medicine specialists to be one of the most impactful clinical interventions available for older adults, and blood pressure medication is frequently on the list of drugs that warrant reevaluation as patients move from their 60s into their 70s and 80s. There is also an important practical point about how blood pressure is actually being measured and what that means for the target being pursued. Many older adults have their blood pressure measured in a standard clinical setting, seated in an examination room, often after walking from a waiting room, sometimes with a cuff that is not properly sized for their arm, and frequently after experiencing the mild anxiety that many people feel in a medical environment. All of these factors can artificially elevate the reading in ways that lead to treatment decisions based on numbers that don't accurately reflect the person's actual resting blood pressure in their daily life. Home blood pressure monitoring, done correctly with a validated device and proper technique, consistently and repeatedly over multiple days and times, provides a far more accurate picture of true average blood pressure than a handful of office readings. For older adults being treated to an aggressive target, knowing their actual home readings compared to their office readings can be genuinely important clinical information, and if there is a significant discrepancy, this is worth discussing explicitly with the prescribing physician. The most important step is to move beyond thinking about your blood pressure target as a fixed, universal number and start thinking of it as an individualized goal that needs to account for your age, your physiology, your symptoms, and your overall health picture. The next time you see your doctor about blood pressure, consider asking specifically what target is being used for you and why, whether that target accounts for your age and overall health status, whether your blood pressure is being measured under conditions that accurately reflect your real-world levels, whether your standing blood pressure is being checked as well as your seated pressure, and whether any symptoms you have experienced, including dizziness, falls, fatigue, or changes in mental clarity, could be related to blood pressure being managed too aggressively for your current physiology. It is also worth understanding that the lifestyle foundations of blood pressure management remain important at every age. Reducing sodium intake, maintaining a reasonable level of physical activity, managing stress, getting adequate sleep, and eating a diet rich in vegetables, fruits, and whole grains all support cardiovascular health in ways that benefit blood pressure management regardless of what the specific numerical target is. These approaches tend to produce more gradual, sustainable improvements in blood pressure with fewer of the adverse effects that can accompany aggressive medication increases, and they are particularly valuable at 70 when the physiological margin for error is narrower than it was in younger years. Before we close, it is essential to say clearly that this video is for general educational awareness only. Nothing here constitutes medical advice, and no one should change their blood pressure medication or targets based on information from a video without direct consultation with their own doctor. Blood pressure management is highly individual, and the right approach for you depends on your complete health picture in ways that only a clinician who knows you can fully assess. What this video can do is give you a richer understanding of why blood pressure management at 70 is genuinely different from blood pressure management at 40, so that you can bring better questions and clearer expectations to your next conversation with your healthcare provider. If this video gave you a new and more complete way to think about your blood pressure numbers, please share it with someone over 70 in your life who deserves to have this information, because this is exactly the kind of nuanced health education that most people never receive until long after it would have been most useful. If you found this video helpful, please like it and subscribe to Dr. William Hart Health for more videos like this every day.